Hi, I'm Dennis Nash, and this week we'll be covering the epidemiology of HIV and AIDS. The outline of the lecture is here. We'll be covering a lot, including the emergence of HIV in the US, an overview of the clinical and epidemiological aspects of HIV and AIDS, the HIV/AIDS treatment era, and a lot on HIV/AIDS surveillance and how to track the HIV epidemic. And as part of that component of the lecture, we'll talk about the epidemiology of HIV in the US. And we'll delve into quite a bit of detail about how HIV is tracked in New York City. Of course, all surveillance is local, ultimately local, and we can't track what's going on nationwide unless we rely on local jurisdictions to do good surveillance. And so we'll delve into how surveillance for HIV and AIDS is done in New York City, and then review some of the information that we've gleaned from HIV/AIDS surveillance here around what the epidemic actually looks like in New York City and how it's evolving. And towards the end, we'll wrap up by talking about the local and national so-called ending the epidemic initiatives. These are initiatives that have been launched both in New York and since then nationally, that are aiming to really reduce the public health threat of HIV to levels below which we can now thankfully achieve theoretically, because we have some amazing tools to help control the epidemic. And then we'll just finally briefly turn our attention globally to the HIV pandemic and how scale up of HIV treatment in resource limited settings has been going. So HIV stands for human immunodeficiency virus. It was discovered in 1983 by scientists at the Pasteur Institute in France. It's a retrovirus that was isolated from human patients with acquired immune deficiency syndrome, or AIDS. HIV is the virus that causes AIDS, and it was discovered as the causative agent about 2 years after the first cases of AIDS were recognized in the US. It's transmitted from person to person by the direct and indirect modalities. And this can happen through sex and needle sharing, through contamination of the blood supply, or through vertical transmission. Basically, it's exposure to blood of infected individuals. The virus attacks the immune system directly. Specifically, it attacks the CD4 cells in the immune system, and thereby makes the host vulnerable to opportunistic illnesses by sort of depleting the immune system or decimating the immune system. The incubation period is about 9 to 10 years after infection. So about 9 to 10 years after infection, people go on to develop AIDS. And this makes it challenging, of course, to identify people with the infection. As we've seen with other infectious diseases, when there's a long incubation period or long asymptomatic period, it makes recognition and diagnosis and disease control very challenging. So there are highly effective treatments available, though. They didn't really come down the pike until the mid 1990s, but they're very effective in extending life and also have the added benefit of reducing or even ending the infectious period when people are on treatment for life. There is no cure, but there is a highly effective treatment. There's no vaccine. There have been several attempts to develop and identify an effective vaccine, but there have been none successful to date. And most recently, there is a preventive tool called pre-exposure prophylaxis, or PrEP, which is a daily pill that people at high risk for HIV can take if they're HIV negative, to prevent acquisition of HIV infection. So first, where it began, there's a good place to start is this MMWR that came out in the early 1980s, 1981, which published a case series of cases of pneumocystis pneumonia in LA that were detected. And these were unusual. They were occurring among previously healthy young men. Um, and it appeared that they had very weakened immune systems. But this is the first case reports of what eventually came to be known as AIDS in the early 1980s. these are hand-drawn early epidemic curves that were made by staff at the New York City Health Department that were used to track cases of AIDS by month of symptom onset, as you can see here. They were tracking both national cases as well as those happening in New York City because the outbreak of this unusual cluster of disease was New York City was an epicenter here. And they were also tracking the different ways that this unusual disease was presenting, both in terms of the pneumocystis carinii pneumonia, which I mentioned that was reported in the MMWR, but also a rare cancer called Kaposi sarcoma or KS. And sometimes these opportunistic illnesses, as they were called, or OIs, could present simultaneously. And here you're seeing another epidemic curve, but it's really showing deaths among people diagnosed with AIDS. And some of the early cases, some of the early cases here are reported, seen here stratified by sex. You may know if you've read the book or if you've seen the movie and the band played on, there was a lot of focus on this on the emergence of AIDS as a gay disease and one that affected primarily gay men. But in fact, there was some pretty early epidemiological evidence and surveillance evidence suggesting that this was something that was affecting both men and women um, from very early on in the epidemic, in the emergence of the epidemic. And here again, showing some of the early epidemiology here, breaking information out by race, ethnicity, by opportunistic illness, and as you can see here, reports of AIDS among people who were heterosexuals as opposed to men who have sex with men, which was the initial focus of the CDC investigation. So it was this is a map that just shows the some of the early cases of AIDS that were presenting in February of 1983, and you can see that the yellow dots sort of showing up in a few places on the map, most notably New York and California, but also a few other places around the country. And so it was really important to institute surveillance for AIDS to understand really the extent to which um, this this phenomenon, this disease that was appeared to be growing in terms of the number of cases. What was the extent of the geographic extent of it? How many people were affected? What does the epidemiology look like? Um, but before we jump into the surveillance part, I do just want to say a little bit about what we've since learned about, where did HIV come from? So where did it come from? Like a lot of pandemics, HIV resulted from zoonotic transmission to humans. HIV crossed from chimpanzees to humans. Actually, the estimates go back to the 1920s, and it appeared to have occurred in the Democratic Republic of Congo in Central Africa. It was probably the result of chimpanzees carrying a virus called simian immunodeficiency virus or SIV, which is closely related to HIV. And it could have gotten into humans as a result of these chimpanzees being hunted and eaten by people living in the area. Since then, some phylogenetic analyses have suggested that the viral genome based looking at analyses of the viral genome from the 1970s and early 80s, it appears that HIV made its way to the US from the DRC, but first by way of Haiti, and then from there to New York sometime in the early 1970s. And ultimately to other parts of the U.S., later on in the 70s. This also matches up with what we know about the natural history of HIV. The incubation period or the time from infection to onset of AIDS is about 9 to 10 years. And so the first AIDS cases began to appear as early as 1978 in the US. So if you assume a 9 to 10 year incubation period, it suggests that transmission could have occurred in the US as early as 1968. So back to surveillance, why is it important? Of course, we need to be able to initially monitor and characterize the epidemic. Initially, it was really just tracking AIDS cases and not HIV without AIDS. As you may know, HIV begins as a viral infection that takes quite a long time to progress for people to present with any disease, and the disease is an immunodeficiency disease. So it takes about 9 to 10 years on average for that to occur after infection. So initially, when it was really poorly understood what was going on, or even whether it was a virus that was causing the cases, um, it became very important to develop a case definition and to conduct surveillance for AIDS. Later on, once it was a little bit more understood what the cause of the epidemic was, um, it became more important to have surveillance that could help understand and detect changes in patterns of transmission. And eventually, when treatment and other services became available, surveillance could be used to help target those and evaluate, guide the development and evaluate the impact of interventions, and ultimately to provide data that funding decisions could be used, such as how to allocate federal funding across the U.S. Because as you'll see, the HIV epidemic does differentially affect citizens by geography. So initially, then it was a clinical case definition that was developed for tracking AIDS. It was not clear initially early on whether it was a virus, so there was no laboratory test available, and it was really a clinical case definition that was based on the diagnosis of one or more of 23 specific opportunistic illnesses. We talked about some of the early ones, pneumocystis carinii, pneumonia, and Kaposi's sarcoma, but there were several others that could fall into the category of AIDS-defining illness. By 1985, there was a widely available serologic test. Once it was discovered that the cause of AIDS was a virus deemed or named human immunodeficiency virus for HIV, a serologic test was developed, and that could be added to the case definition. And so you could have people with the clinical syndrome and then also confirmed with a laboratory diagnosis, which greatly helps with surveillance. And eventually it was expanded to include, in 1993, to include some additional opportunistic illnesses that were found to be associated with AIDS, and also added a criteria for CD4 counts below 200. So even if you didn't have an opportunistic illness, if your CD4 levels dropped below 200, that would classify you as an AIDS case as well. And this was tracked through a combination of active surveillance, provider reporting, and then beginning in 1993, lab reporting as well. So just going back to the map here, again, advancing a little bit forward in time, as of 1985, there were about 10,000 cases around the U.S. You can see the number of dots in more places than before, and I'm just going to zip through a few years at a time here so you can get a sense of how the epidemic spread. By 1989, 100,000 cases around the U.S. And by 1995, 500,000 cases, much more in the way of geographic spread. Um, and finally, by 1997, there were about 626,000 AIDS cases that had been diagnosed around the U.S. And by 2003, there were estimated to be about a million cases of AIDS in the U.S. In the process of conducting surveillance and also epidemiological studies, We learned a lot about the ways which HIV could be transmitted beyond what was initially thought to be limited to sex between men. It became clear that it was also transmitted by heterosexual sex, needle sharing, and injection drug use. Um, and even to a lesser degree with risk, but non-zero oral sex. And also early on, there were well-documented cases of HIV being transmitted by blood transfusion. And so once a lab test was available, it was possible to actually screen and increase the safety of the blood supply from HIV transmission, but very high risk associated with blood transfusion with blood that was contaminated with HIV, and also mother to child transmission. About 25% of the time, if a pregnant woman is infected with HIV, about 25% of the time, her newborn will also be infected with HIV. So through surveillance and through um, observational cohort studies and research that was aiming to understand the different modes of transmission and risk factors, and also to sort of quantify the risk associated with them. We've since learned a great deal about the ways in which HIV can be transmitted. A little bit about the life cycle of this virus. HIV attacks cells in the immune system, specifically the CD4 cells. As you can see, the red circle sphere here represents the HIV virus and its genetic material, the RNA inside. It enters through CD4 receptors into the cells, the CD4 cells of the immune system, and its RNA makes its way into the membrane into the membrane of the CD4 cell nucleus here, and that RNA virus is incorporated into the machinery of the cell itself, and the virus begins replicating within the CD4 cells. And the virus can replicate so prolifically that there are so many copies of the virus within the CD4 cell that it kills the CD4 cells, and it bursts, and copies of the virus get released and can infect other cells. And so at the same time the virus replicates and spreads, it also destroys the immune system. And this is why we see these very pronounced opportunistic illnesses that are really unusual to see in people, except for those with severely compromised immune systems. So understanding the life cycle, of course, is really important for understanding the natural history of HIV infection, which in turn is very helpful and important for epidemiology and surveillance. Um, Although a lot was learned about the epidemiology of HIV before understanding, that it was a virus and its life cycle and things like that. So, but also understanding the life cycle is critical for basic scientists who are focused on developing treatments and vaccines and things like that. So this is a slide that just shows the like a schematic of the natural history of HIV. I believe this was some of the early work of Dr. Anthony Fauci, who's a household name these days. Much of his early work, or much of the early work on HIV, was led by Dr. Fauci as well. And the schematic here that comes from their early work shows that when HIV infection occurs, this is showing the level of CD4 cells. So a person without HIV infection may have, upwards of 1,000 CD4 cells per cubic millimeter on average. But then when infection occurs, showing here on the red line, the copies of the virus begins to replicate and increases. And that produces a initial sort of rapid decline in CD4 cells. Initially, the CD4 cells in the immune system appear to gain control over the virus. And so you see a decline in the amount of virus circulating, somewhat of a recovery, but not full recovery of the CD4 cells. But over time, the virus continues to replicate, and the CD4 cells continue to decline, and ultimately can be, really quite depleted. And after a period of about 8 or 9 years, the CD4 cells get below that threshold of 200 that I mentioned, and this is when the risk for opportunistic illnesses can begin to increase, and when symptoms can begin to show. And with time, without any treatment, this will progress to death. And I also want to say that this represents, from an epidemiological standpoint, one of those big challenges in the control of infectious diseases. There's a very long asymptomatic period here in people with HIV. So people can be going for years and years without showing any symptoms or knowing that they may have the virus, and that makes it very challenging to identify those who may be infected, diagnose them, and treat them, but also inform people about ways that they should change their behavior so that they can prevent onward spread to others. So these long asymptomatic periods, such as we've seen with HIV and other infectious diseases, really present some significant challenges to control of these infectious diseases. Over time, scientists began to test some different treatments, and there was one very early one called AZT, which was tried in people with HIV to sort of prevent disease progression. And you can see on this slide here, there was a slight slowing of disease progression. They looked at a number of different outcomes. AZT did appear to slow disease progression a little bit. Then they began to try different combinations of drugs, so two drugs at a time, AZT plus another therapy. And you can see one of the first trials here. This one was led by Scott Hammer at Columbia as part of the, for the larger AIDS clinical trials group, and including the AZT plus a second drug really did improve the proportion that did not have a decline in CD4 count over time, or develop AIDS, or go on to die. So these were really some promising developments in the area of treatment for HIV, treatment for a disease, an infection that was pretty much deadly, very deadly. Some of the outcomes here, you can see this was looking at the change in CD4 count over time. For those that only got AZT, you can see they had a bit of a improvement in CD4 count, but over time it began to continue to decline. But those that were in the other groups seemed to fare a bit better in terms of their CD4 count decline over time. But still, it was not something that continued to increase CD4 count progressively and moving it back to where it was prior to infection. This was still looked like a virus was outsmarting some of these treatments. And I should say that the different treatments that were developed and tested as part of these early trials were targeting different parts of the HIV life cycle that we saw on the earlier slide. So they're focused in different places. And ultimately, a third drug was added and tried in another trial, and so-called triple therapy, or a highly active antiretroviral therapy was tested in a clinical trial, and this showed the results that many were really looking for. So long-term suppression of the virus, lowering the viral load to a very low level, not just an improvement in CD4, but sustained improvement over time, and continue to increase as time went on compared to the control group. And of course, the proportion of people surviving over time that did not go on to develop AIDS was lower in the treatment group. So it really did slow disease progression. And this in the mid-90s really ushered in the so-called treatment era for HIV. And so effective treatment was for HIV was was proven to prolong life, to delay progression to AIDS, reduce some of the the very challenging and difficult outcomes associated with HIV, like hospitalization, frequent hospitalizations, and opportunistic illnesses, drug resistance, and raise the possibility that controlling HIV or treating someone with HIV to reduce the amount of virus that they had circulated in their blood could reduce the spread of HIV, the risk of spread of HIV from an infected person to an uninfected person. We'll come back to that. So, what do the population-based data tell us about the impact of HIV in the U.S. after it emerged in the 1980s? It was really quite impactful. Eventually, among people aged 25 to 44 years, HIV became the leading cause of death for a while until the treatment era ushered in. But you can see, fairly rapid increase compared to the other leading causes of death in this age group. Um, and since then, as treatment became more widely available, the death rate dropped substantially and has continued to decline. Although it's taken quite a while to get it down to levels that really have been theoretically achievable given the effectiveness of the drugs. This became a question of not whether the drugs were effective enough, but whether or not it was possible to get them to everyone who needed them at scale. So some of the vital statistics data really showed the impact of HIV on the death rate. It was the number one cause of death for a few years um, in younger age groups. And this is a map just showing the rates of diagnosed HIV infection. So this is prevalence of diagnosed HIV infection. As of the end of 2017, it was estimated that there were about 1 million people living with HIV in the US. And if you were to calculate a rate, actually 1 million people diagnosed and living with HIV. This is important because a substantial proportion of people with HIV are not diagnosed, and I'll come back to that in a second. But from surveillance data, the number of diagnosed HIV cases as of end of 2017 was about 1 million for a rate of about 369 per 100,000, or about 0.37% of the US population. And you can get a sense from this map here that it is highly variable depending on what part of the US you're looking at. So New York, the coasts are very highly affected, and this happened very early on in the epidemic, and increasingly the southern U.S. has been much more hard hit than other states around the U.S. This is a map that shows the issue I alluded to a minute ago. What proportion of those million, or what proportion of people with HIV are diagnosed and know that they have it? And you can see this also varies by state, but all across the US, about 86% of people living with HIV have been diagnosed. So about 14% of people with HIV around the US are infected but don't necessarily know it yet. And this proportion also varies a lot by state. As you can imagine, the more people the greater proportion of people who have HIV who are aware of their infection, the more you could do, have effective control measures and improve access to treatment and things like that. And in places like New York, which is doing very well, over 90% of people, it's estimated that here about over 91% of people with HIV are aware of their infection, but it can really be quite low in some other areas. For example, less than 85% in some areas of the South. But when you sort of adjust for this level of undiagnosed HIV, you can then begin to estimate the true number of people living with HIV, not just those diagnosed. And it's almost 1.2 million as of the end of 2018. And you can also come up with prevalence estimates to give you a sense of the numbers of people and how it really varies from state to state. And now this is looking not at prevalence, but at the number of new diagnoses per year. And this is for the year 2018. So in 2018, an estimated 37,741 people were diagnosed with HIV around the US. And this is more, it's not quite new infections or incidents, it's more like new diagnoses. People diagnosed with HIV in 2018 could have been infected in 2018, but they also could have been infected, years earlier. So this is just reflecting the number of people with newly diagnosed HIV, and you can see how it really also varies across the U.S. But more diagnoses are happening in the South and in the Northeast, when you consider the number of people in the population. So the diagnosis rate per 100,000 population. So taking some of these surveillance data on diagnoses of HIV infection, these are HIV infection, not just AIDS anymore. You can see that pretty much from 2010 forward, this is the surveillance data show a much higher rate of diagnosis of HIV among males compared with females, and that really hasn't changed much over time. You can see there have been some shifts in age groups, but pretty much consistently over the last 10 years, those aged 25 to 34 years are having the highest rate of new HIV diagnoses. And we've been seeing some declines in those aged 35 to 44 years, as well as those aged 45 to 54 years. Looking at the diagnosis rate by race ethnicity, you can see consistently from 2010, Black or African Americans have had made up the largest proportion of new HIV diagnoses, followed by whites and Hispanics or Latinos. This has been, shifting a little bit over time as well, and an increasing proportion of new HIV diagnoses are occurring among Asians. In terms of risk factor information, this is something that you can get from surveillance data, and the predominant category of risk that is captured in surveillance is male-to-male sexual contact, followed by heterosexual contact, injecting drug use, which appears to account for a declining proportion of new HIV diagnoses, and then the combination of male-to-male sexual contact plus injecting drug use. And this is a slide that's going further back in time. First of all, to give you, we were looking from 2010 forward on the previous slides, but this is now going back to 1985. But the other thing that's different here is that we're looking at the outcome of an AIDS diagnosis, not just HIV. And so these are severe cases of HIV, of course, people that have progressed to the point of having AIDS. And you can see there's been a fairly substantial shift in the racial ethnic distribution of AIDS cases. Initially, this was predominantly white people that were affected by AIDS, and over time this shifted, and there was an increase in the proportion of AIDS cases that were Black or African American, as well as those who are Latino or Hispanic, and also multiple races. This represents partly the underlying epidemiology that shifted in terms of the risk of infection, but also I mentioned the treatment era that does prevent the progression of HIV to AIDS really began around 1995 and 1996. And so some of these rates are also influenced by the availability of treatment and who had better access to treatment over time. And in 2017, in terms of the deaths, there were estimated to be about 16,000 deaths due to HIV in that year. And you can see, not only how the numbers break down, but also the rates. And there are major disparities in the death rates due to HIV, with 17.4 per 100,000 among African Americans compared with 4.4 or 2.6 among whites. So a many-fold higher risk of death due to or death among people with HIV who are African American or Black compared with other race ethnicities. And this also can give you a sense, this slide showing you a sense of how the risk factors for HIV changed over time since the early 1980s. It was predominantly male-to-male sexual contact, but as I alluded to earlier, HIV was also known to be transmitted through other modes, including injecting drug use and heterosexual sex. Um, the risk factor of injecting drug use and heterosexual contacts both increased and accounted for a greater proportion of AIDS cases over time, and that also led to a decreasing proportion of male-to-male sexual contact as the predominant risk factor. But since then, there has been a big decline in the number of new infections among people who inject drugs, and things have begun to, this has shifted the epidemiology and what are the more common modes of HIV transmission and progression to AIDS in this case. And it's important because the as you can see this risk factor for male to male sexual contact primarily is a risk factor for males, and so it's really important to stratify the this risk factor distribution by gender. And what you can see here is when you do that, that among men it is male to male sexual contact that is far and away the most common risk factor. However, for females, it's heterosexual contact and followed by injecting drug use. So the risk factor profile um, for HIV is different by gender. Lastly, another really useful and this is a really great success story of HIV. I mentioned the risk of transmission of HIV from pregnant women to children to their children. This is something that the HIV treatment era really had an impact on, and since treatment became available in the mid 90s, the number of perinatally acquired HIV cases has declined substantially, and I'll show you some more data later on for New York City, and it has gotten close to zero around the U.S. And this is a major public health triumph in the control of HIV. So let's just take a step back because it's always important to when interpreting some of these data on infectious diseases and epidemiology to think about where the national surveillance data come from and where the data come from in general, population-based data on HIV. Well, as we know from the prior lectures on surveillance, these data come from providers and laboratories they report information to local public health departments, who in turn send it to the state and then on to federal levels at the CDC. Um, and I guess, a question to sort of ask, do national data that we've seen, for example, I presented you a bunch of information on the epidemiology of HIV for the US, do they provide enough information for public health action at the local level? In other words, can we take national trend data and sort of say, this is what is likely reflecting what's happening in New York City? And of course, by now, you guys know the answer is definitely not. You need local information, local epidemiological data to inform action at the local level, because what's happening in one place with regard to transmission could be very different from what's happening in another place. And so we're going to delve into how New York City implemented named HIV reporting. This harks back to a couple different lectures, but we talked about the ethics of surveillance and named reporting in one of our, as part of the surveillance lecture. Um, we talked about how prior to HIV reporting, really only AIDS cases were reported. So only those cases, only those individuals with HIV whose infection had progressed far enough to put them into having immune compromised status or develop an opportunistic illness, only then would surveillance begin and those cases would be tracked. However, as we know, a large proportion of people with HIV infection can exist for many years without any symptoms, and it's important, and those symptoms may not occur for many years. So it's important to think about surveillance a little bit more upstream in the process, because um, if you only track AIDS cases, you'll only have an idea of what may have been going on with actual transmission of HIV, some 9 to 10 years earlier. So this is something that happened around the year 2000 in New York City. Several states and other jurisdictions had been moving towards transitioning from AIDS surveillance only to HIV plus AIDS. And this is just a picture of what it looked like in terms of the number of AIDS cases reported by metropolitan statistical area. New York had by far the most AIDS cases of any other city around the US. And at the time, the population of New York City was about 8 million, about 36% foreign born. And based on the surveillance data on AIDS to date, about 50,000 or 48,416 people were thought to be living with HIV, living with AIDS in the city. But there was, because there wasn't surveillance for what happened with people with HIV before the development of AIDS, there was not any good estimate of how many people were living with HIV that had not progressed to AIDS, and therefore no sense of how many people were living with HIV in total around the city. So this was sort of the rationale for the surveillance system, was that it was important to understand more about the epidemiology of HIV across the entire spectrum of HIV infection and disease. So, just in terms of the history, like the rest of the country, from 1982 to 1993, it was really about AIDS-defining illnesses and OI diagnoses or opportunistic illnesses. That was really what surveillance was based on. And in 1995, the diagnostic test, the serologic test, was added as well, but it was basically done by active case surveillance by health departments and passive reporting by providers of new diagnoses of AIDS. In 1993, a CD4 laboratory test was added, so all CD4 counts less than 200 by labs would have to be reportable, and that was combined with active surveillance and passive reporting. So now passive reporting included laboratory reporting in addition to provider reporting. And in 2000, the surveillance system was expanded greatly to include active surveillance for both HIV and AIDS, with passive reporting by providers and labs. So, with named HIV surveillance, HIV/AIDS surveillance in New York City, this is what's currently reportable. Any new diagnosis of HIV infection, regardless of whether or not the person has progressed to AIDS, any new diagnosis of AIDS, even if the person was previously reported as a new case of HIV without AIDS in the past. Any information on known sex and needle sharing partners, so that contact notification and partner notification could take place. And laboratories would report on positive serological tests, viral load tests, CD4 tests, and more recently, the results of resistance testing, which is a common practice of providers who are treating HIV patients when there's evidence that the patients are not responding to drugs. The concern is that they could have drug-resistant HIV, and so there are genotyping tests that can be done to look for that, and those tests are reportable as well. So Since 2000, many millions of provider and laboratory reports have been received by the New York City Health Department, and just to give you a sense of the universe of what of where active and passive surveillance occurs in New York City, or at least in 2000, at the time there were about 80 hospitals that could be reporting AIDS and HIV diagnoses, about 500 freestanding clinics, and about 2,200 private medical care providers, all of whom could be diagnosing or treating people with HIV. And there were about 70 labs or so that were licensed to conduct HIV-related tests on New York City residents. These could be labs in New York City and New York State, but also elsewhere around the country, wherever laboratory testing might be done. But if a laboratory is licensed by New York State to do HIV-related tests on New York State residents, that lab would be required to report that information to the state and to the city. So labs and provider reports, come into the health department, and then they need to be sort of processed and translated from, data points, laboratory reports and provider reports into useful epidemiological information for surveillance. And I'm just sort of flashing up, sort of the flow diagram, the process that has to be sort of considered when when evaluating every piece of information that comes in relative to all pieces of information that have been received in the past on individuals, just to sort of decide, is this person a new diagnosis? Is this person someone who's diagnosed previously? Have they progressed from HIV to AIDS? And so forth. And just is it a duplicate of someone that we've seen before? A lot of data management and data processing goes on behind the scenes in surveillance in order to, sort of get to this stage of, processing all of this information. And you could sort of really call it magic. It is a lot of work and details. I go into more detail in our surveillance course about how this is done, but um, all the information that is received gets processed into epidemiological information that we can then sort of evaluate and look at sort of the trends. Um, but in the year 2000, when the laboratory, when the surveillance system transitioned from only tracking AIDS cases to tracking AIDS cases as well as HIV cases that had not yet progressed to AIDS, um, we learned a great deal of new information about the epidemic, the epidemiological information. One of the first things was that we could calculate um, the diagnosis rates for HIV. We were now tracking um, all diagnoses of HIV, not just those of AIDS. So we could look at we could calculate the rate of diagnosis per 100,000. And as you can see here, we did this in a given year. This is for 2001. Overall, about 0.75 new HIV diagnoses per 100,000 population. And you can see that it really varied a lot by race ethnicity. This is showing the rate among Black males, Black females, Hispanic males, Hispanic females, white males, Native American males, etc. And you can see that there are very big differences by race ethnicity in the diagnosis rate of HIV in that first full year of HIV reporting in New York City. And then we could also calculate estimate the prevalence of HIV. So how many people were diagnosed and living with HIV around the city? Overall, we estimated that there were about 1% of New Yorkers were diagnosed and living with HIV. But again, because surveillance captures other information about people diagnosed with HIV and AIDS in New York City, we could estimate this by race ethnicity. And here showing, we were very surprised to see extremely high rates of HIV prevalence in New York City. 2.3% of Black males in the city were diagnosed and living with HIV, 1.6% of Hispanic males, 1.2% of Black females, 1.1% of white males. So all of a sudden we get a much clearer picture of what the HIV epidemic looks like in New York City through the expansion of this surveillance system. And this is a slide that was put together by our commissioner at the time, Tom Frieden, which basically compared what was going on in New York City to the rest of the United States. So we estimated that in the US, 1 in every 250 people were HIV positive, compared to 1 in every 70 people in New York City. And then breaking it down in other different ways, 1 in 40 African Americans in New York City, 1 in 10 or 10% of men who have sex with men, 1 in 8 injecting drug users, 1 in 5 Black men aged 40 to 49 in Manhattan, which is just staggering, 20%, and 25% of men who have sex with men in Chelsea. So the new surveillance system really opened up a lot of opportunity to gain insight and then respond to what was a very extensive HIV epidemic in some communities and populations around the city. So I'm just going to fast forward a little bit. That was the year 2001, 2002, and a little bit after that. But I'm just going to fast forward now to just highlight some highlights about what the recent HIV surveillance data for New York City are showing. The latest report goes through December 2018, the end of 2018, and through surveillance, they have now identified about 127,000 people diagnosed with HIV and with HIV in New York City. Um, this is an aging group of people, although there are new HIV infections among younger people, but about close to 80% of people living with HIV in New York are 40 years or older, and 60% are 50 years or older. The majority are men, but about 26% are women and 1.5% are transgender. 76% are Black or Hispanic, 42% are men who have sex with men, and about 13% of those living with HIV report a history of injection drug use. And then, so that's all people diagnosed and living with HIV in New York City. And if we then look at those who are newly diagnosed with HIV in 2018, it gets you a little bit closer to like who is being affected and acquiring HIV more recently. So there were about 2,000 or 1,900 new diagnoses of HIV in 2018. Importantly, 19% of them were concurrent HIV and AIDS diagnoses. So about 20% of people diagnosed with HIV in New York City had probably had HIV infection for 8, 9, 10 years prior to this. So still there's a lot of people with long-standing HIV infection who just aren't diagnosed until the time that they present with symptoms. And these are major missed opportunities for saving life with available treatments as well as preventing onward spread. And one sort of persistent theme here is that MSM minorities, minority women, and young persons do continue to be heavily affected by HIV AIDS in New York City, with some of the breakdowns here. Importantly, it's really hard to get good information on risk factors. So while we can say that 54% of newly diagnosed males were among men who have sex with men, risk information is still missing for about 23% of people. The vast majority of new HIV diagnoses in 2018 were among Black and Hispanic New Yorkers. And looking at the younger age group, about 39% of the new diagnoses were among people aged 13 to 29. So this is not just something that is affecting older people, it's still something that affects younger people in New York City. And this is a set of maps that's included in every annual report that the City Health Department puts out. It shows the map of poverty. This is not an HIV related map here on the top left, but it shows the map of poverty by New York City neighborhood, and then it shows how HIV diagnosis rates vary by neighborhood in New York City. And of course, you can see the overlap between poverty and HIV, new HIV diagnoses in New York City. This map shows the prevalence of HIV, so those neighborhoods that have the highest number of people diagnosed and living with HIV. And this last map on the bottom right shows the age-adjusted death rate by neighborhood. Importantly, this is an era where, and this is a city where HIV drugs are widely available or should be for free to anyone who needs it. There are all kinds of systems in place to help make treatment available to those who need it and who are diagnosed with HIV. So in a perfect world where everything was working the way it should, we should not see any differences in the death rate among people with HIV by neighborhood. This is using people with HIV as the denominator. It really should be, you know, one color across here, and it should be very low, given how effective treatment is. But in fact, what we see is that, you know, it can vary by as much as 15 or 20 fold from one neighborhood to the next. Another thing that is really important to look at is this is not just related to the prevalence of HIV, like where there are more people with HIV, there are higher death rates. In some instances, that's how it works. But let's take a look at the high HIV prevalence in Lower Manhattan here. This area of the city has among the highest HIV prevalences in the city, but they have among the lowest death rates. And so this suggests that there are some major differences and inequities in access to care by New York City neighborhoods. And also, you know, just flipping back up to the map of poverty, you know, this is also a part of the city that is not as affected by poverty, but is affected by HIV. But some of the other areas that are greatly affected by both also tend to have higher death rates. So we have major access to care and services issues in the city that still need to be dealt with as it relates to HIV and many other and many other health outcomes. One of the things that I like in this report that the City Health Department puts out, the surveillance report, is they have these spark lines in here that just sort of give you a sense of what the trend looks like in different groups over time from 2001 to 2018. So you can quickly glean from this chart that for the most part, new HIV diagnoses are declining in almost every group since 2001. You do see some different trajectories in different groups, though. And this is the chart related to perinatal HIV transmission in New York City. It shows the number of children who are born to HIV-infected women each year. And in red, what we're seeing is the outcome of when the child became infected. And in blue is the outcome that we're hoping to achieve, which is when the child is not infected. And looking out to recent years here, well, first you're seeing fewer and fewer numbers of children born to women living with HIV, and also much more in the way of blue here, including 0 cases in some years and very handful of cases since 2012. So this is that major national success story I highlighted earlier about reductions in perinatal HIV transmission. New York City is certainly doing really well in this regard. This happens because it's increasingly possible to diagnose most women who are pregnant with HIV through antenatal care testing programs that are happening all across the state. When women with HIV are pregnant women with HIV are identified, they can start treatment, and that greatly reduces the risk of transmission from mother to child, and also cesarean section further reduces that risk. And so these numbers reflect the important process of recognizing pregnant women with HIV infection, treating them, and also the cesarean delivery. So this is just a graph that sort of shows the history of the entire epidemic in New York City of HIV and the added information that sort of came when the surveillance system expanded to include HIV, non-AIDS. And so this is sort of completing the epidemiological picture here. Um, and now we can track the number of people living with HIV, all of them, not just those that have gone on to develop AIDS, and also new HIV diagnoses, alongside AIDS diagnoses, and the curve here showing the trend in the death rate. Importantly, like we saw nationally, major declines in HIV, in deaths among people with HIV, but it's still been kind of slow going, and still not as low as it could be given how effective the treatments are. And this reflects this implementation issue, this access to care issue, that is a very important area of work to really help our city benefit as much as we can from all of the treatments and technologies that are available. So I hope I've kind of conveyed here that we've we've been able to measure a lot of things about the HIV epidemic. We've looked at the incidence and prevalence of AIDS. When treatment came along, tracking AIDS cases only is not really indicative of what was going on with HIV transmission, years earlier. It was then beginning to reflect that plus a mix of, who was accessing treatment and when. Um, and so we've since evolved surveillance in New York City and also almost everywhere around the country to be able to track not just AIDS but HIV. Um, and we've shown how it's possible by understanding what proportion of people with HIV are undiagnosed. We can estimate the overall prevalence of HIV, not just those that are diagnosed. And we've also looked at the epidemiology of HIV diagnoses, new HIV diagnoses. What we haven't talked about is the incidence of new infections, so true incidence. The number of people diagnosed in a given year, I mentioned it, it's really it's a mix of people who may have been recently infected, as well as those who have been infected sometime in the past, maybe years ago. And so it's important to know who's getting infected with HIV today when starting to plan for HIV prevention activities, and wanting to know who to target for HIV prevention and where. And so this was an active area in around the time that New York City was implementing its new HIV surveillance system, which really was about, what we want to do to control HIV is to reduce the number of new infections each year. For us to do that and for us to know if we're doing that successfully, we need to be able to measure new HIV infections. And this is a tricky thing to do. And there have been many approaches to trying to estimate HIV infection over the years. You can do it with cohorts, but cohorts are not necessarily representative of the general population. You really need population-based estimates of HIV incidence. There have been a couple of like laboratory-based strategies to sort of infer HIV incidence estimates, but most recently, CDC has moved into a system that is sort of a modeling-based system that leverages population-based surveillance data, and the fact that people are that surveillance captures information on CD4 counts. If you remember back to that graph I showed you at how after HIV infection, in untreated HIV infection, the CD4 count progressively declines over a period of years. And something that's implied there is that if you know someone's CD4 count with someone who has HIV and their CD4 count, um, you can, on average, have a sense of like how long they've been living with HIV. So, for example, someone with a CD4 count, a very low CD4 count of 100 or 50, it's likely that they've been living with HIV for, on average, maybe 8, 9, 10 years. And people with very high CD4 counts have been living with HIV for less time. And the CDC and others have developed something called a CD4 depletion model, where they use those CD4 count values reported to surveillance to sort of calculate and estimate what the HIV incidence was, as well as HIV prevalence and the percentage of undiagnosed HIV infection. It's a very interesting and elegant model, and I'm not going to present the details of the model that they used here, but you do have the publication here if you want to learn more about how it's done. But through this modeling approach, it's possible for CDC to use population-based surveillance data and the CD4 counts that come with it to come up with estimates of true HIV incidence, the number of people newly infected with HIV in a given calendar year. And with their model, what they've done and shown here is that since 2010, they estimated that it was about 40,000 new infections each year in the U.S. And it's pretty much remained level and maybe started to trend downward a little bit, although the precision of these incidence estimates appear to be worsening. But for the first time, CDC now has been producing pretty reliable incidence estimates for each calendar year over time, and they're more recent. So here we have data going through 2018. They've been able to stratify this information by some of the same variables that we looked at with HIV diagnoses. And we're seeing some of the same trends here, right? New HIV infections, how they vary by sex, how they vary by age, how they are varying by race, ethnicity. Really not much in the way of change happening here, except in some groups it may be even on the rise, like Hispanic and Latinos. And it's also, possible to point out the very, stark disparities by race ethnicity that we're seeing in the HIV incidence estimates for the U.S. For example, Blacks and African Americans make up 12% of the U.S. population, but 42% of new HIV infections in 2018. Hispanics and Latinos, 17% of the population in the US, 28% of the new HIV infections. And comparing also this to whites, you see that while whites make up 62% of the population, they make up only 25% of new HIV diagnoses. And this last slide shows trends in the incidence over time by risk transmission category. Again, showing what we saw with new HIV diagnoses, with MSM contact being the most common transmission category, followed by heterosexual contact and injecting drug use. So basically, the HIV surveillance system with incidence added to it, using the modeling approach, uh, really conveys what a comprehensive view of the US epidemic we now have. We can track new diagnoses, we can track prevalence of diagnosed HIV. We can use that to estimate the overall prevalence of HIV, including the prevalence of undiagnosed HIV. We can track deaths over time, both to all-cause deaths and other causes, like such as HIV-specific deaths or other related deaths among people with HIV. And we can track the number of new infections over time now, true incidence. All this is just to say that, in the area of HIV and our understanding of HIV infection in the US, we have incredible epidemiological capacity to monitor key aspects of the epidemic using population-based data. I can think of very few other public health threats and infectious diseases that we can characterize this well. And we also have, in addition to the population-based data that come from health departments and other sources, we have non-population-based research data that really add depth, tons of research studies that add depth on behaviors or the efficacy of different strategies and interventions, and and so forth. So we really are fortunate to have a lot of intelligence and information on the epidemiology of HIV and how to control it. I alluded to this earlier about how HIV treatment, in addition to helping the individual who has HIV and prolonging their life expectancy, it's also was thought theoretically possible that treatment of HIV could reduce the risk of individuals with HIV spreading it to others, such as sex and needle sharing partners. And there was a landmark study in the New England Journal around 2011, which was the HIV Prevention Trials Network, HPTN, Protocol 052, which randomized, it enrolled serodiscordant couples, so one person with HIV, one person without. And it randomized half of the couples and treated the HIV patient as usual according to clinical protocols versus earlier than usual. So that was the sort of difference, early treatment with HIV versus treatment as usual. And what they saw was that the transmission rate in the serodiscordant couples in the group of people with HIV that were randomized to early treatment, the transmission rate was reduced by 96%. And this was very rigorous randomized trial evidence that treatment for HIV was also very effective at preventing HIV transmission, and it ushered in what is called the treatment as prevention era for HIV, and this has been a cornerstone of the response to HIV, the HIV epidemic in the U.S. and the pandemic globally. So treating HIV improves the health of the person with HIV, and it has a public health benefit of reducing transmission. Another huge development is the development of something called PrEP, or pre-exposure prophylaxis, and this is a pill, a daily pill, or an on-demand pill that someone who is at risk for HIV infection can take to prevent the acquisition of HIV. And this is a slide that is showing the results of another really important trial that showed the efficacy of pre-exposure prophylaxis at preventing HIV to be very, very high. So it's another very effective tool that we have for HIV prevention, as well as the very effective treatment. And so we have tools to substantially reduce HIV acquisition, and that would be PrEP. And we have tools to substantially reduce deaths among people with HIV that are very effective, namely treatment, and also effective at preventing onward transmission, right? 96% reduction in onward transmission among people who start treatment early. But there are major, major implementation gaps. So it's one thing to have really effective tools on hand. It's another thing to get them to everyone who needs them at the scale that is needed. So we're in this situation where we have all kinds of great evidence-based strategies for HIV prevention and treatment, and we are at the place, and this is the field of implementation science of HIV is really focused on how do we bridge this gap between the efficacy, the high levels of efficacy that randomized controlled trials promise, and the effectiveness that we want to see in the real world when we attempt to take these interventions to scale. So just to give you an idea of what we are talking about here, I mentioned, I think we covered that there were about 1.1 million people living with HIV in the US. So to maximize the impact of treatment, we want to get as many people, as close to 100% of people with HIV on treatment and with suppressed viral load on treatment early. But what we actually see when we look across the entire US, of those 1.1 million or so people, estimated to be living with HIV. Only about 86% of them have been diagnosed. So that's the first step where we have a gap. And then there's getting people from the point of being diagnosed to actually engaged in medical care, to begin to receive care, and then to be retained in care over time, and ultimately to the point of viral suppression. And if you look at these estimates, across the US, what we're seeing is only about 56% of people living with HIV have gotten to this point of viral suppression, which can improve their life expectancy as well as reduce the likelihood of onward transmission. And so this is why these gaps, these are the reasons why we're seeing continued new infections due to new HIV infection, and also a continued trend in a substantial number of deaths due to HIV every year in the US. There have been a number of attempts to sort of move to sort of the next level of implementation, including a national HIV/AIDS strategy. The first ever was launched by the Obama administration in 2010 and then updated in 2015, which really called on focusing on some of these gaps, improving HIV testing, linking people to care, and improving access to treatment, and trying to achieve universal HIV viral suppression among people living with HIV, for the reasons we've discussed, as well as expanding access to the pre-exposure prophylaxis PrEP services that we know are very effective at preventing HIV acquisition. Just to compare this, New York City is doing considerably better than the nation as a whole, but there are still, many gaps that remain here as well. So, of the 100%, if we're looking at the full denominator of people living with HIV, here you can see there's still about 7% who are not yet diagnosed, and a lower proportion that have received care or have been prescribed drugs, and only 77% of people with HIV in New York City have sort of gotten stable on treatment, so that they are no longer they no longer are transmissible. Their HIV is no longer transmissible to others. This is a graph that shows HIV incidence estimates for New York State over time. And you can see that while there has been progress at reducing the number of new HIV infections, they've kind of leveled off. This is some earlier data showing what was happening between 2010 and 2014. And this prompted our then governor and now governor, Andrew Cuomo, to launch an Ending the AIDS Epidemic in New York initiative, or an ETE initiative. This is an initiative that has since been launched in many other jurisdictions around the US and around the world. New York was one of the first, and it set out with an ambitious goal. Well, I mean, I'd say it set out with a goal that maybe could have been even more ambitious than it was, but to reduce the number of new infections from about 3,000 to about 750 per year by the end of 2020. And you can see the focus points here. It really is on some of these implementation gaps. Getting people who have HIV who are not diagnosed tested and linked to healthcare, and treat people with drugs, HIV drugs, as soon as possible to keep them healthy and to prevent onward transmission, and also scale up access to PrEP. As part of that initiative, the blueprint that came from that task force that the governor had convened on to identify ways to the strategies to end the HIV epidemic in New York. One of them was related to surveillance and included the creation of a dissemination system that was web-based and public-facing, so that people could see the progress of this initiative towards achieving its goals. This is a dashboard system that actually our team at CUNY was chosen to develop and run for the initiative. And I just wanted to show you a few screenshots of it here. But its purpose is to measure and track this progress that the state is making on achieving its goals of ending the HIV epidemic in New York. And we developed a bunch of metrics that are aligned with the goals of the initiative. But we wanted to create a way of visually interacting with some of the data, the surveillance data, and other data that were relevant to this initiative. And the system has been live for a few years now. You can check it out at ete-dashboardny.org to get a sense of what's going on with trends in HIV-related outcomes and PrEP use over time. Um, if you go there, you will see a bunch of different metrics that are part of this initiative and how those metrics are doing. For example, this is incidence in New York City. Going from about 2,700 new infections in 2014 down to close to 1,500 in 2018, and this is the target. So you can get a sense of what the trend looks like in relation to what the goals of the initiative are. These are the kinds of metrics you can check out on the website. Since then, there has been a national Ending the Epidemic initiative called EHE, Ending the HIV Epidemic. And they have also created a dashboard system that you can check out that will show you what's going on around a number of HIV-related indicators in different key jurisdictions around the US. And you can find that by Googling ahead ending the HIV epidemic or going to hiv.gov. So that wraps up the section on HIV in the US, and I just want to close by covering a little bit about HIV globally and in resource limited settings, because it's a very different environment, of course, and there's a lot more HIV in resource limited settings than we have in the US. So just to give you a sense of how it fits in, we talked about how there were about 1.1 million people living with HIV around the US. Well, globally, it's about 38 million. So you can get a sense of the fraction of all HIV prevalence that is made up by people living in the US with HIV. Most of the HIV infection is concentrated in the sub-Saharan African region here, among 38 million people with HIV globally. And in this region, you can have very high population level prevalence. I think we were seeing prevalence rates of less than 1% in the US, but in some settings in sub-Saharan Africa, you can see prevalence rates well above 1% in at least 8 countries, higher than 10% in the population. So just to give you guys a sense of where this fits in globally, you'll recall from the Global Burden of Disease Project, the visualizations that show the distribution of deaths according to cause, and the red ones here are the infectious causes of death globally, and you can see where HIV fits in. And if you look at the other metrics, such as years of life lost, you can see that the share of deaths that infectious disease takes up, or years of life lost in this case, increases, as well as the role of HIV in driving the burden. This shows the ranking in the cause of death in 1990 compared to 2019, and you can see that HIV/AIDS was number 30 in terms of the cause of death globally, and over the course of these 29 years has risen to number 11 globally. Um, it wasn't until about 2003, some 7 or 8 years after highly effective treatment became widely available in resource-rich settings, that the global community began to mobilize around the idea of providing HIV treatment in areas of the world that were really hardest hit by the epidemic. And there were really three major initiatives that were sort of moving the field forward. It was the Global Fund for AIDS, TB, and Malaria, the World Health Organization's 3x5 initiative, and the US-based unilateral effort called PEPFAR, or the President's Emergency Plan for AIDS Relief. This is the largest of all of the efforts. It initially focused on about 15 countries, most in sub-Saharan Africa, but provided tens of billions of dollars over subsequent years, aiming to increase the number of people on HIV treatment in the hardest hit areas of the world, as well as several other important goals. How would this work? Was that the money would be provided to implementing partners and national programs to work together in country under the direction of the national HIV care and treatment programs and their guidelines within the larger health system in each country, usually within the public health and within the public sector clinics and service delivery settings. Um, the care is provided by local healthcare providers, but the implementing partners, who might be from the US or Europe or other resource-rich settings that were involved in providing the technical assistance, would work with in-country partners on training and mentoring and capacity building, drug delivery, and increasing and improving the laboratory infrastructure, and just general technical assistance around service delivery of HIV related services, working in direct partnership with national programs. But you can get a sense of what the challenge looks like in many resource limited settings. In sub-Saharan Africa, in many settings, the healthcare system really was in crisis due to years of neglect and under-resourced approaches to providing healthcare, and overcrowding. And so this made it very challenging to begin to advance a very large scale initiative to deliver drugs and testing and diagnostics and care services to millions of people. But it nonetheless was the setting that was that everyone had to work with when these initiatives began. But these challenges included, a limited prevention armamentarium. Of course, treatment is, you want it to be your last resort. Ideally, you would be preventing infections so that you didn't have to treat them over the course of someone's lifetime. There was also very high rates of both late diagnosis and late treatment initiation, making the cases more complicated to manage clinically, and also increasing the mortality rates following treatment initiation. Several other challenges, including, sometimes on again, off again commitment from international donors because of political issues or because of, global financial trends. And this makes it very hard for ministries of health and other national entities to plan what needed to be, really programs that need to last decades. Um, just to throw up on the timeline here, to give you a sense of, we really began, uh, got highly effective treatments for HIV in 1995, but it really wasn't until 2005 that the world really turns its attention to HIV in resource limited settings and treatment. And this was a time when there were about 31 million people living with HIV around the world, but only 4% of them were on treatment. This was really something that was limited to resource-rich settings, and the goal of some of these initiatives to provide treatment in resource-limited settings beginning in 2004 and 2005 really was a large-scale initiative, unprecedented in many ways on the scale of from a public health initiative on the scale of the smallpox eradication campaign that we heard about a few weeks ago, or last week actually. What did this look like? Again, going back to 2005, of the 28 million people living with HIV in 2005, only 2.2 million of them were on treatment. But rapidly, with this influx of resources and international commitment to working with resource-limited settings hardest hit by HIV, you begin to see really massive increases, millions of people placed on life-saving treatment over the course of about 10 or 15 years, such that by 2018 there were 23 million people on life-saving HIV treatments, but still with a major amount of room to improve. This is a schematic that just shows a similar concept of the implementation gap that we saw in the US. And you can see globally about 79% of people living with HIV are aware of their status. And of those, about 78% are on HIV treatment. And of those, about 86% have sort of achieved this treatment goal of being virally suppressed, such that um, their life expectancy will improve and they will be less likely to transmit HIV to others in their lives. Um, but this amounts to about 53% of all people living with HIV having achieved viral suppression. What do the trends look like globally? This is showing the trend in new HIV infections on the top, so HIV incidence, and the trends in AIDS-related deaths over time. You can see that globally we peaked at about 2.5 million infections every year around the world, and by 2019 we were at about 1.7 million new infections per year. Um, and in terms of deaths, we were between 1.5 and 2 million deaths a year, and major progress with increasing access to treatment around the world. Now about 690,000 deaths every year. These dots represent the targets that have been set globally, and you can see we're very far off on the incidence target here, but we are close to achieving the 2020 targets. They won't be achieved, but we're at least closer. And this reflects our success at getting large numbers of people onto HIV treatment, and our success to a much lesser extent on HIV prevention. So you can see the progress here. This is the same ranking chart that I showed before, except this time instead of 1990, I'm showing you 2004. And you can see that the HIV/AIDS as a number 6 cause of death globally has moved now to number 11. And if you focus this, if you just redo the same chart for sub-Saharan Africa, you can see how, in terms of the number of DALYs, HIV/AIDS went from number 1 to number 5 over the course of about 15 years. And this is real progress as a result of the world's effort and the world's focus on the hardest hit areas of the world when it comes to the HIV pandemic, with resources and services and drugs. And I'll just leave you with this. Next week we'll be focusing on TB and malaria, other major leading causes of infectious disease deaths in sub-Saharan Africa and around the world. I hope you all have a great and safe week ahead, and I look forward to seeing you all soon.